Hello, can everybody hear me? Hello?
Yes, we can hear you loud and clear. Go ahead. Continue.
So these are the team that was involved in this presentation. And then our learning objectives will be, we'll take a look at the novel coronavirus 19, a bit of the pathophysiology, epidemiology to help understand the clinical features. And then we'll quickly come down on the protocols in management of a pregnant woman up until her delivery and then the postnatal period as well. We'll be discussing this topic under the following outline. We'll look at an introduction, a brief overview, epidemiology, clinical features. We'll take some case scenarios, some investigations, and then we'll go down to the meat of the matter, approach to antenatal and delivery. And then we'll look at it, we'll talk on our conclusion. Now, we've heard a lot about the coronavirus in several of our webinars we've been having. It's a novel virus, and it causes the coronavirus disease called the COVID-19. The coronavirus 19 is found in a family of coronaviruses that causes a lot of other syndromes and diseases, which are already listed on the slide as shown. Now, it's known that this virus is a single-stranded RNA virus, and it gets into the cell using the ACE inhibitors type 2. Upon getting into the cell, it navigates into the cytosol, and then it starts to cause this damage through translation of proteins and other things that we'll be talking about as we go along. So for a brief overview, the healthcare facility, usually in this time period of the pandemic that we're in, we should ensure we try to strengthen our health system on counseling, because counseling can be done through video calls, that's telemedicine, phone calls, etc., which is already in place in Limi Hospital. Now, this is not to say that the obstetric care of the pregnant woman will be neglected or is pardonable, no. However, we need to weigh the two, that is, the pandemic we are facing that has a high fatality rate, case rate, sorry, and then of course, the need to also give optimal best care to the pregnant woman. So, in as much as we are trying to give her the best care, we should also focus on screening, especially when they need finally to come down to the hospital, good hand hygiene practices, good respiratory respiratory etiquette, and then infection prevention and control. The pregnant woman, unfortunately or fortunately, as the case may be, undergoes some physiological changes in pregnancy. And these physiological changes in pregnancy, unfortunately, mimics some of the symptoms that you may see, or even the signs as well, when there's a coronavirus infection, that's the COVID-19 infection. And in fact, sometimes you may be faced with a dilemma because the woman will come in with fever, a rupture of membrane, so you have to take an astute history, you evaluate her properly, so that you won't end up calling infection of pregnancy, maybe choreo and chorioamnitis, and say, okay, oh, she has fever of more than 38 degrees. You say, okay, perhaps it's coronavirus. So it's a kind of clinical dilemma, but there are ways in which we try to calm down on if this is actually an obstetric presentation or having a high suspicion for coronavirus disease. Now, pregnant women also, it has been found by a lot of studies that they are not more susceptible to the consequence of infection with COVID-19. So during counseling, which is one of the objectives we just talked about now, we must try to allay the fears of our pregnant women that come. Everybody is panicky, everybody is, has a lot of questions to ask. We should tell them they're not unduly susceptible to this infection or even the consequences of it. However, they should adhere to the hygiene practices that we keep teaching them at every point in time when we have the opportunity to meet with them. In cases of uncertainties, like I talked about chorioammonitis, it's good to seek additional advice. Or sometimes in cases of an emergency and you have a suspected case, we'll be defining what a suspected case is. Then it is better to err on the side of suspecting that she is a coronavirus patient and then trying to put in place the proper mechanism that is in line with what your local hospital practice, and then at the end of the day, you have a better outcome. So now, in as much as we are here to give care to all our clients and to make them feel comfortable, it's important to also know that this coronavirus disease has an asymptomatic stage. And during this stage, there is still some form of transmission of the virus. So it is sufficing to get used to know that we should get used to the clinical, the hygienic practices and safety code protocol that we'll be talking about subsequently during this period of the pandemic we're facing now. So this is a graph that really talks about how resource intensive and specific this presentation is. What do I mean by this? Now, majority of our clients that may end up having this corona disease or even an corona disease may end up just having the mild symptom. And usually the mild symptom, basic care, clinical care will suffice for them. And so while trying to allow them to go through the 14 days observable incubation period per se, the basic clinical care can also be afforded to them. Particularly in our own low resource setting, where getting tested when you have the mild symptom is not usually easy to be done, to do. So we should still acknowledge the fact that the mild the mild disease, basic clinical care will suffice for them, because not everybody that has this mild disease will end up coming down with the critical or severe form of the disease. Now it's resource intensive in that majority of the people that have the critical and the severe and critical form of this disease will require high intensive care in the ICU. And this is not without the resource that is needed to procure ventilators, to procure health personnel, etc., etc. So the message of this slide is to let us know that even though, yes, most of our clients may end up having the mild form of the disease, the basic clinical care will suffice for them, and then it will help them throughout the incubation period, and subsequently they may end up testing negative at the end of the day. Now, a brief epidemiology. We've heard a lot about this. It's originated in Wuhan, China, and presently it's a pandemic. It affects a lot of regions in the world. The first time it was pronounced as a global pandemic was in March of 2020 this year, while Nigeria recorded its first case on the 27th of February. Presently, as of now, we have more than 2,300 cases. So this is something we should all take seriously and also get to know exactly the mode of transmission, how we should manage it, and how we should help to allay the fears also of our clients as well. Now, several incubation periods have been talked about, 0 to 14, some say 0 to 24. But the most important thing is that if we practice the hand hygiene we talked about, And of course, we practice social distancing and staying home, and of course, reducing the number of times the clients come to the hospital unnecessarily, in quotes, thereby utilizing our video, telemedicine, etc., would help to curb the transmission of this disease, and very soon, hopefully, reduce the spread of the disease. Now, the incidence is really, really difficult to ascertain. Why? Because a lot of people are not being tested. However, it's encouraging to note that throughout all the series that I tried to go through, no reported deaths in pregnant women have been noted. So, meaning that we in obstetrics and gynecology, we have a form of ray of hope, in the sense that, well, even if we find out that a woman has the coronavirus, we can still manage her and we can still have a good outcome at the end of the day. Now, it's also interesting to note that no data showed increased risk of miscarriage as well, or early pregnancy loss. However, recent data, the last 2-3 weeks, because this is an ever dynamic disease, people are just getting to know what it is. The previously presumed mechanism of mode of transmission, pathogenesis, most of them are being crossed out now. Presently, as we speak, it also is implicated in preterm labor. However, the data or the case series that were reported is not a good evidence to show that categorically it may be caused by only coronavirus. Perhaps some of these women had high risk factors, such as a previous history of preterm labor, or even a history of cervical incompetence, etc. So, but we must bear that in mind as well. Interestingly also, intrauterine infection with COVID virus have not been proven. We'll look at some case reports as well that showed that there was no evidence of this as well. And so by extrapolation, congenital infection by this virus in fetal life is also not proven as well. This is very encouraging, because lots of our clients, they come here, doctor, how will it affect my baby? I'm so scared. Well, with all this information, we can actually allay all their fears, and then make them understand that, yes, if you stick to the protocol of good hand hygiene, social distancing at least 6 feet, and staying home, exercising, eating well, then at least there's some form of hope. And this is really encouraging to the obstetrical community. Now, for the transmission, previously it was known as a zoonotic, which just means that it's transmissible from animals to man. We've talked about the bats, we've talked about the different, a particular animal, penguin or so, but presently what is most important is the community spread. And that's why now we have now skewed our screening history to ask community spread in Nigeria. Right now, no global traveling as of now. So we don't need, we wouldn't really focus on, have you recently gone abroad, or have you recently traveled to California, etc. Rather, we would rather focus on some of the states that seem to have high incidence, high new cases, and then of course use that as our travel history. Now, talking about community spread, because there's lockdown in virtually more states than none, we would also inquire about contact, because this is a formidable factor in community spread of this virus. Now, the other mechanism of spread is through the respiratory aerosol. It is said that if a person who is infected should sneeze or cough or laugh, and it's in a particular environment or in an enclosed room, the virus can actually stay there for 24 hours On solid surfaces, I think 8 hours or so, and even through fecal routes as well. Poor hygiene after using the convenience, and then, of course, improper hygiene as well, because some people will just go, okay, yes, I've washed my hands. No, washing hands with soap and water for at least 20 seconds. So these are the mechanisms of spread that are now very, very important presently now. We'll be talking about the pathophysiology of this and then expatiating on it subsequently. Another good news, there's been only one case of a possible vertical transmission. What do I mean by vertical transmission? That's from mother to child through the placenta. And so this also will come in handy in the counseling by healthcare professionals as well. So down to the pathophysiology. Now, like I said, previously it was a zoonotic, so meaning that it was known to be transmitted from animals to man, bats, pangolin, etc. But presently, we're going down more on human-human transmission. Now, this virus is a single-stranded, it's a positive sense single-stranded RNA virus. And it needs an agent to get into the cell. So what happens is that any cell that has the ACE inhibitors type 2, which is the angiotensin converting enzyme inhibitors type 2, the spike proteins on the virus goes and binds to these ACE inhibitors, and then this helps to carry it in or transmigrate it into the cell, aiming at the cytosol. At the cytosol, the cell uses the molecules found in the cytosol, such as the ribosomes, the Golgi body, etc., to now propagate itself vis-a-vis making of new proteins from messenger RNA. Remember, it's an RNA virus. So it undergoes translation and forms new polyribosomes. Now, another point also to understand is that there is a reverse transcriptase enzyme that helps it to get immortalized into some certain cells that it may find itself in. For example, let's take example of the lungs, for instance, that has alveoli. Now, these alveoli, the coronavirus possess the RNA-dependent RNA polymerase. Now, what this RNA polymerase does is that it immortalizes itself in the alveolar cells, for instance. And when it does that, it now multiplies and then produces RNA more, it replicates itself and produces more of this virus. And at the end of the day, it bursts out of these cells, and it's responsible for several mechanisms that have been known to be postulated, because there are lots of postulates as we speak, and the clinical features associated with it. For instance, when there's bursting out and then there's replication, there's release of cytokines. And when these cytokines are released, macrophages are now chemo-attracted. And when they come in the bid of trying to do good, trying to mop up all these bad cells in quotes, what happens? They release some more cytokines, interleukin-1, interleukin-6, and also tumor necrosis factor alpha. Now, that interleukin-1 and 6 could migrate into the systemic circulation and go and stimulate the hypothalamus that will now produce prostaglandin E2, which is implicated in the causation of fever. And that's why one of the commonest symptoms we would see is that there's fever. Now, also, apart from that, the cytokines cause vasodilation. Now, why am I going into this? Because when the patient finally, or when the pregnant woman finally comes down with some of the symptoms and complications, we'll be able to follow it gradually. Now, it causes vasodilation and also leaky capillaries. So there's transgression of fluid into the interstitial space. With that, the alveoli, which are implicated in production of pneumocytes type 1 and 2, are now inhibited in the function. So when the type 2 pneumocytes have an inhibited function because the shift of fluid into the interstitial space now causes a kind of collapse on the cytokines. And then, since their functions are inhibited, they cannot produce surfactants. When they don't produce surfactants, they don't produce these surfactants are necessary to maintain the tensile strength or tensile pressure, as we may say, in the alveoli. And this keeps them open and they are able to function properly. Now, when this does not happen, then the cell could collapse, apart from the fact that there's pressure from the surrounding egress of fluid too. This could now lead to that respiratory distress, increased respiration to try to increase the function to get more oxygen because of the destruction from the type 2 pneumocytes. Now, apart from that, these interleukins too could also go and stimulate, like I said, the hypothalamus, causing fever, etc., and the other pathophysiology involved. So when a patient comes and the patient has fever, the patient has cough, the cough too is also implicated in the pathophysiology. Patient has difficulty in breathing. Some of these are also implicated in all the pathophysiology that we just talked about. So from this diagram now, it's divided into phases. The viral response phase, which we talked about, the immortalization of the cell, etc. And then the host inflammatory, I'm using my arrow now, my cursor, host inflammatory response to these phases. The release of cytokines, the macrophages engulfment, neutrophils are also implicated as well. They come in and cause their own havoc. And then you have all the barrage of symptoms that you may get. Now, the different drugs are targeted at the different sites of the different mechanisms we talked about. We'll expatiate on it later. Now, we've talked about this viral integration, replication, and response phase. And then we talked about, we used the lungs as a case scenario. However, cells that have high representation or high levels of ACE inhibitors could also be affected. Now, recently, they've been talking about the GI symptoms, eye symptoms as well, conjunctivitis. All these are all implicated from the pathophysiology that we just spoke about. Other organs too can be seen here as the arrow is going around and then all that. Now, we talked about release of cytokines, etc. Now, these are the clinical features. Like I said, during the asymptomatic phase, between 0 to 14 days, some people have even talked about 24 days, mean of 0 to 5. You may be, the patient or the client may be asymptomatic, but still can transmit the virus. So this is just a diagrammatic expression of all what we talked about. And then, of course, enumeration of the symptoms: asymptomatic fever, cough, shortness of breath, chest pain, muscle pain, headache, sore throat, etc. Yes, so back to our antenatal and pregnancy screening. So basically screening, we screen you taking a detailed history. What are the history? We've talked about it: history of fever, cough, difficulty in breathing, shortness of breath. Shortness of breath. Unfortunately, most of our clients, in the bid to protect themselves, not knowing that they will hamper the care we give them, may want to deny most of these symptoms. So, well, most often than not, we may get the history of fever, but cough and difficulty in breathing, most often than not, they usually not say they don't really experience that. Now, in In other centers, now we have divided centers into high-income resource countries and then low-income resource countries because of the peculiarity of finance, availability of manpower, availability of equipment, etc. Now, for high-income resource centers, there's a rapid assessment of airway, breathing, circulation, and vaginal bleeding. Now, take the 3ABC, airway, bleeding, and circulation. In our low-resource center, the honest truth, we cannot be rapidly assessing all this because in doing that, it will not suffice. Reason being that our PEPs are not readily available. And if you need to do an airway assessment properly, you should have a complete PEP. So what we do, we use screening of number 1, which we have talked about. The cursor is there. And then, of course, if she's bleeding, it may or may not be obvious. However, it's easy to elicit the travel history within Nigeria. I've said it that it's more important than travel history now because of the embargo on international travels. And of course, the contact too. So these can be a screening protocol as well. Now for investigations, of course, the real-time polymerase chain PCR is the gold standard, but it takes a long time to get the results. So basically, we could rely more on the symptoms, history of contact, before we can get the result, meaning that the patient will be on isolation for the period of time prior to when the result can be obtained. Another good test is the nucleic acid amplification test. However, it's extremely expensive. I think it costs about $300 or so. And then, of course, there's been this speculation shifting boats on gene expert tests. What happens is that the gene expert test machine, there's this customized cartridge that can be incorporated into it, and then it can help us to test for positivity or negativity of the virus. So at least it's important to mention this. Now, some other investigations which may arise, very, very helpful due to the clinical features, especially of people that are symptomatic, will include the complete blood counts. So for the complete blood counts, usually what gives it away is the lymphopenia. About 80% or more will have lymphopenia. And that lymphopenia could raise a red flag for us. Of course, we've talked about the NATs, that's the nucleic acid amplification test, which is really not feasible in our own setting. And then, of course, we talked about some particular tests that will be affected, especially when the patient ends up having acute respiratory distress syndrome. We have the arterial blood gases, and of course, the partial pressure of oxygen stroke FiO2 ratio, and procalcitonin. It's very important to mention this because if there's a secondary bacterial infection, this usually will be raised. It will be raised. However, if it's just a clear-cut COVID viral infection, this will essentially be normal. Another thing is that general markers of inflammation will also be elevated. However, some of these markers are most of the markers are really non-specific. And even more still, the D-dimer in pregnancy is already elevated. So are we looking at taking a baseline now and then taking subsequent tests later? Or are we looking at a particular value? All these are all subject of research, rich arid areas of research. Ferritonin as well could be elevated. Troponin is very important. Then for the chest X-ray, the CT scan as well, and then the ultrasound scan, these tests have been shown very, 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 very important in the management of the COVID-19 patient as well. Due to, of course, we talked about the fact that patient may come in acute respiratory distress syndrome, you do a chest x-ray, you see features of interstitial, you do an ultrasound. Let me start from the ultrasound. You see features of interstitial edema. You also see, sometimes you can even see the B lines. The B lines are hypoechoic in nature. Hypoechoic in nature on ultrasound, they are essentially white. And then you now see them, and then of course you can make the diagnosis. You can entertain the diagnosis then. While the chest x-ray, well, it's sensitive, it's sensitive but not specific, in that other things like influenza virus infection, etc., could also have those chest signs that may be seen as well. We'll talk more on the different features of the ultrasound, the chest x-ray, and the CT scan data. So let us look at the next topic, which is the approach to antenatal proper. So when a client that has been cleared, because now in Limi Hospital we have the privilege of having video consultations. If the patient decides to key into that, and then she comes in and tells us, oh, she has A, B, C, her symptoms, and then we feel it, yes, she can come in, no problem. However, if they still present on their own to the hospital facility, they must be encouraged to perform hand hygiene. This will help to reduce the transmission. And then, of course, at this point in time, it's really mandatory that they wear face mask. At least now, the idea is that you keep your infection to yourself, I keep my infection to myself, and then we will reduce the transmission and subsequently reduce the incidents, new cases coming up as well. Now, it's very sufficing to note that we should also place particular posters to remind them about how to perform this hand hygiene on strategic points, and also how to wear the face mask as well. And then I will not overemphasize the place of counseling, because really a lot of people are panicking about the outcome, whether it's safe to breastfeed, which we'll talk about, the postnatal care, how they should care about themselves. Unfortunately, it will be really not, it's not advised, because the American College of Obstetricians and Gynecologists and the Royal College of Obstetricians and Gynecologists, and also our national guidelines, have advised that we cannot continue to have our routine antenatal visits, because there will be increased contacts. And remember, one of the mechanisms of reducing the spread is by observing the social distancing, and of course, staying at home, isolation. However, even if we need to delay their routine appointments, we must understand that if at the end of the day we are delaying their appointment, she comes in, oh, I have felt reduced fetal movement, and we want to delay the appointment, and she ends up having an IUF, intrauterine fetal death. That's not too nice. That wouldn't suffice at all. And even some people have even talked about litigations post-COVID. So we should try to strike a balance between observing this delay in routine appointments and also trying our best to give our patients the best care. Now, for those that finally end up in the hospital, in addition, in the waiting room, like what we do here in Limi Hospital, because we don't really want to be saying, oh, madam, please, could you stand up from here? Could you sit there? No, what we do is that we put some instructions on some chair. Please do not sit on this chair. And at the end of the day, we are indirectly achieving this 6 feet apart, even when they come in and they are waiting to see their doctors. So now, if we have a suspected or confirmed COVID-19 case, basically, I'm going to highlight some of the things that have been advised, because really all these bodies are just giving us advices, and it's changing. Everything is changing. Today, what will be advised today may not be obtainable tomorrow. So number one, if there's a suspected or confirmed case, a suspected case is a case that either has those symptoms we talked about, or have a history of contact with a confirmed case. Why a confirmed case by case definition is a case that has taken the test and has tested positive. So they are obliged to tell their status to whoever is driving that car so that at least a face mask may be worn by the driver, and also the windows will be left open, etc. So when they are being transported to the facility, they should endeavor to use a private transport and to also declare their status if it's obtainable. So once they get to the premises, triage, like in Limi Hospital, we have just one gate opened, and that encourages the triage system. I must say it's not very, very easy to triage because some patients are actually confrontational. I just came to the hospital. No, just continue placarding and, coercing them to like oblige. I was in the hospital this morning, and a patient came with cough. A patient brought the baby with cough. The son, not really a baby, 4-year-old with cough. And then a personal physician was seeing the patient. And the patient was vehement, really talking, and I could perceive from my distance, just watching, that he wanted the boy to be nebulized. But of course, at this point in time, you must go through the basic treatment first. Like now, nebulization should be the tail end. Salbutamol will do very fine. That's Ventolin, etc. Don't be pressurized, because at the end of the day, if this transmission is not curbed, we may end up not seeing a decrease in the incidence of this COVID-19 virus. So back to triaging, there must be triaging as soon as she comes in. Of course, triaging while she's being ushered gently to wash her hands, and of course to try to get a face mask if she doesn't have. We're talking about routine appointments. Unfortunately, growth scan, especially for women that are at risk, the oral glucose tolerance test for women that have risk factors, and of course, the appointments are all going to be delayed, because one thing for sure is that someone will have to do all of these tests, except if it's really, really, really necessary for us to do this. It's advised for it to be delayed until when it's really important. So another thing is that fetal surveillance can really be done, like we have a Doppler. Thank God we've passed the stage of peanut stats, where you stethoscope, where you really needed to put your ears down there and then listen. We have a Doppler, so we can actually listen to the do fetal surveillance using the Doppler. However, like we said, the ultrasound scan, it should be really necessary before we ask them to go do it. Then we'll also make sure we identify the high-risk patients, that even we still need to do some particular tests to make sure we have a good maternal outcome. And it must not be, it's not overemphasized. If you're in doubt, please know where your limits are, and then inform someone ahead of you, someone that you know that could give you a good decision. Because like I said, there's been some talks about post-COVID litigations. Then of course, we have talked about for the obstetrics care, delay. I'm just re-emphasizing all this: isolation, infection prevention and control, and of course, ensuring that pregnant women who need to be attended to, if they are a suspected or confirmed case, must contact their local care coordinator, and also book an appointment if it's necessary. That's if it's an urgent appointment. And then finally, they've said that if the patient is a suspected or confirmed case, the consultation should be preferably at the end of the working day. So the appointment should be scaled or skewed towards the end of the working day, so that even if she's around and she's there, she's not being, other people are not being exposed to that particular confirmed, more importantly, case. Then of course, the members of staff should be alerted before entry. And then, of course, they should have their personal protective equipment. So at this point in time, we'll talk about what we should use at the entrance. The mask will suffice if it's properly worn. The mask, being it a cloth mask, would suffice, because at this point in time, we are just keeping any infection to ourselves. The patient is keeping his or her infection to his or herself. And of course, in addition to the mask, if you need to touch the patient, which you really don't have to the entrance, you can wear the gloves. But however, if we'll go to that later, if you are examining a patient, it will be sufficing to have your gloves on, and then afterwards you properly remove your gloves and then take it and then dispose of it properly. Then of course the women should also be masked with the normal surgical or even cloth mask, normal cloth mask or even surgical mask, in that order. And then if they need to be admitted for whatever reason, perhaps she came in with contraction, for the suspected with contractions, sorry, preterm contractions, if she's a suspected or confirmed case, as we have already defined, she should be in an isolated room. And that room should relatively operate in a negative pressure. What do we mean by negative pressure? Meaning that if there is if you have like an AC in the room, it should blow. It should blow in the direction that faces towards the patient. What do I mean by that? The managing team or the members of the team should be before the patient in that order. So the AC, the managing team, and then the patient, of course. And then particularly the negative pressure, meaning that even if there is air blowing into the room, it should be inwards, not outwards. So that's the negative pressure in comparison to the surrounding area. So let me take it again. If there's an AC in the room, the AC shouldn't be directly in front of the managing. Maybe if you are consulting her, it shouldn't be in front of you. Maybe the patient will be sitting before you and then as a healthcare provider. The AC should be behind the healthcare provider and then the patient, and so it blows in a forward direction. And then, of course, in comparison to the surrounding environment, the air from the room should be blowing outward. So if it's an isolated room, the window is, the air in the room should blow out into the surrounding area, not blow out into another room. Then the isolation rooms, okay, these are for patients that maybe post-surgery, you have a room, or patients that are on admission for a long period of time. You have a room where you assemble the PPE before you enter the room, and then you have a room where you can remove it, etc. So these are just advices from various bodies. Then to continue on the essentials for taking care of the suspected or confirmed COVID patients, only essential staff should enter the room. And we will talk about the categories of staff that should enter the room. It's usually in a team. And then the patient should be allowed with one visitor, because this visitor will come in handy in helping the patient to do some of those things that she may want to be done. But visitation is strictly not allowed. Why? Because of the transmission that we all talked about. Then for rooms that perhaps maybe a laboring room that we have, like we have a scan in our labor room, you should also remove all the things that you really don't need. Like remember the amount of time the virus can really stay on surfaces. And if someone comes in, touches it, and then doesn't perform the early hand hygiene that is really recommended, and then now touch some mucosal surface, maybe your eye just starts itching you, or you just try to remove something from your mouth or something, you get inoculated. So on non-essential items should be removed from the room. And then cleaning, very, very important. The cleaning of places that are high density areas, like the doorknobs, surfaces like we talked about, the chairs, etc. We do it early, and it's really something that we should really incorporate in our various centers. So like we said, in the ideal case, not are low resource income countries, usually if a woman has mild symptoms, she should have diagnostic swab arranged. It's so important. And then she should be advised to stay home or stay in a self-isolation for 14 days. And subsequently she'll be tested. And after having a negative test of after 3 days, that should be repeated as well. But these are in ideal settings. Now I've just talked about the duration when she should be retested. We talked about telemedicine, which is very much functional in LIMI, very good. In fact, I've had patients' feedback. Apart from video calls, the WhatsApp group, very functional, especially for antenatal patients. In fact, we've been having some beautiful topics during antenatal on our WhatsApp group, and the women are so happy. They are so happy because, number one, they don't have to face that beautiful, that handsome doctor that may be making them shy and talk about some things they want to talk about, intercourse in pregnancy, blah, blah, blah. So, but now we have this group, WhatsApp group in LIMI Hospital, and we've been really unleashing very salient topics to them through that group. And their feedback is really encouraging. So telemedicine works and it's good. But of course, always try to discuss with a senior member of staff so that whatever you are relaying back would have been properly evaluated. Now, remember that the incubation period is something that is very important, and sometimes you may encounter new symptoms, and when you do, you should be ready for that. So if you are attuned with, of course, the hygienic practices that we've been talking about for the past 15 minutes, you shouldn't be perturbed when you know a woman that you've been managing suddenly now has symptoms. Hey, am I infected? No. Deal with it, you diagnose it, and then you continue from, you give her the appropriate management. But we must understand that there are asymptomatic carriers that are transmitting the virus. Now, the national guidelines in conjunction with Federal Ministry of Health, among there were 47% of reported cases of COVID-19 virus patients amongst pregnant women. Sorry, let me take it again. Now, the COVID-19 patients, only 47 of them had preterm delivery. That's what I brought up at first. You know, initially, that was like a month ago, we were very happy in the obstetric community that there wasn't any report of preterm delivery. But recently, and this was this month, they recorded 47%. So, meaning that we may need to be very careful when we are delaying their visits. Very importantly, have an astute history, properly evaluate them, video call, phones, and then before you now decide, are we going to delay their visit or we are going to come in and then evaluate them further. Now, it's been recommended also in the antenatal period, the use of corticosteroids. You know, one of the mechanisms in pathophysiology that has been postulated is that there could be some form of immunosuppression because some diseases, some patients that have comorbidities have been shown to be more susceptible to the virus. So questions now arose, and people were asking, should we still give? But it's been advised that we can give to women that have preterm labor, especially at risk of preterm delivery. However, you must rule out infection because that one now increases the chances of complication. You should also learn the validation of the gestational age as well. And there should be a team, pediatric team, ready for neonatal care. We cannot overemphasize the role of call to hospitals, especially during early labor. In fact, now it has been emphasized that during early labor, what you do is that you ask her, Madam, sorry, so how many contractions are you having now? How long does it last? And then you ascertain, you also ask her if she's having any other symptoms. Has she seen water? Has she seen catarrh with blood, which is show? Is she bleeding? And then by that conversation, you may elicit latent phase, which is really termed early labor. And it has been advised that patients that have latent phase can actually labor at home, especially those that are first timers with no other added symptoms. Why? Because remember, latent phase is an innocuous state. And in fact, some women stay in that latent phase for up to 24 hours. But you can still induce them. But of course, we are talking about reduced contact. So it's been advised, and it can stand anywhere, that you can allow them to labor for a while before they now come in active phase when they get to 4 cm. But this is what is advised. We've talked about masks, we've talked about infection prevention, care response team, we've talked about the number of persons, we've talked about triaging, we've talked about the place of the mask, and of course, even when they come into our hospital unit, we should also observe that 6 feet rule. We can put in instructions in between chairs so that they don't sit too close to each other. Then, of course, for the healthcare provider, if you need to perform a procedure that generates aerosol, please, you should wear the N95 mask or the other cohorts of that same variant, not just the surgical mask. Now, for places where home births are allowed, not our setting definitely, the midwife can lead a team, and then they can actually go and assist in the home birth. Then, of course, we have also re-emphasized the need for fetal growth monitoring, and then delaying, because of course, the new report that shows that there is some form of acute to chronic placenta changes. So based on this now, when she now also comes in the intrapartum period, when I say intrapartum, that's during labor, you could put her on a continuous cardiotocographic tracing without the tracing paper, because unfortunately during labor, there's been some incidents of fetal compromise. So of course, if you have had, if you have the continuous electronic tracer on, you can easily detect it, institute intrauterine fetal resuscitation, left lateral position, which is on oxytocin, you clip it off, you give her normal saline to help dilute the oxytocin in the circulation, and also to improve circulation. You also monitor the fetal heart after 10 minutes, and then you now take your decision thereafter. Now, an electronic fetal monitoring serves in two ways. One, reducing close contacts. Yes, we have a Doppler, we can use it, but it increases it reduces the distance from the patient. But with our electronic monitor, we can increase the distance, and we don't really need to go too close too often. Number two, checking the fetal heart every 10 minutes can be cumbersome, but with the electronic monitor, you can just take a look, and then you can look at it and take a decision. So it's really it's really advised during the intrapartum period. Now, let us talk about the multidisciplinary approach, especially for those that have comorbidity. Once the patient comes in, especially the centers that manage the severe COVID-19 patients that have severe symptoms, such as maybe a pneumonia, the critical patients that have acute respiratory distress syndrome, there must be a multidisciplinary team in place ready to respond, because this improves the outcome of the patient. And then, of course, luckily for us, we have monitors, patient monitors that can hook up to patient and then to monitor the patient's vital signs, especially the oxygen saturation in severity. Then, of course, during postpartum care, you need to confirm that she's in established labor, she's 4 cm dilated, and she's having adequate uterine contractions. And then you decide on the next line of management for this patient and the electronic fetal monitoring using the cardiotocograph. Now, supposing she comes in, like we said earlier on, she has signs of sepsis, fever, she's perhaps rupture of membrane, signs of maybe hypotension, increased pulse rate, etc. We should manage her as an in the obstetrics protocol, using the obstetrics protocol. However, we should have a high suspicion of COVID-19. So ideally, you have all those symptoms, the fever, rupture of membrane, maybe difficulty in breathing, you should at least take a swab for testing. Now, what are the swabs you can take? You can take the nasopharyngeal swab. You can take sputum, but the most common is the commonest, is the nasopharyngeal swab. But you can even take sputum. You can take blood. But what we have here, nasopharyngeal swab, or sometimes the oropharyngeal swab, if it's available. Then we talked about the multidisciplinary team, especially for patients that come in suspected or patients that are confirmed. They consist of the consultant obstetrician. You must inform the anesthetist, the midwife in charge, the neonatologist, and of course the neonatal nurse as well. All these people will help in giving us a good outcome. And luckily for us, in this era of pandemic, COVID-19, we've been having really, really appreciable outcome. We look at some case scenarios. Then, as much as possible, when she's laboring these suspected or confirmed cases, the minimum amount of staff should enter. What do I mean? If the obstetrician needs to have a review, you have your review and you leave. The midwife, if she needs to monitor her, and you go back to your safe distance as the case may be. But the amount of personnel at a particular time must be at the barest minimum. Now, we talked about oxygen saturation, at least greater than 94%, especially when the patient is on oxygen therapy. It's very important. And then early monitoring of this saturation, especially by doing the pulse oximetry. So down to route of delivery, there's no evidence with respect to a particular route of delivery when you're managing a COVID patient. The only exception is when the patient has acute respiratory distress syndrome, where it should be advisable for her to have a cesarean birth to adequately decompress the uterus, and then she can quickly start getting the treatment she deserves with regards to this. For other mild cases, moderate cases, you should, the route of delivery should be dictated by obstetrics indication for whatever route that is chosen. So it's not as though every COVID-19 patient should have a cesarean section. Like one series talked about 9 of them all had cesarean sections. It should be at the barest minimum. Then the delay of elective cesarean section should be is also advised. Like one of my patients, 2 previous cesarean section, obviously we were planning her for a cesarean section. This era came, we postponed it for a week, another week, only for her yesterday to have an emergency CS. So it's like you keep weighing everything. You keep weighing it, especially for those that are asymptomatic. Then we also talked about management for comorbidities. The physicians should be involved, endocrinologists should be involved, etc. So when the baby is now born, during the postnatal period, it's advised that the nasopharyngeal swab and the umbilical swab can be tested for the suspected mothers. Then also a good history on this neonate, checking out for symptoms and signs, is also advocated. Universal isolation, either from a confirmed or suspected mother, unfortunately is not recommended, especially in these low resource setting. Why am I saying that? We are in a low resource setting, and the breast milk, the advantages of breast milk and maternal bonding cannot be overemphasized. It has psychological advantages, physical advantages, mental development, etc. So the evidence we are seeing is not enough to allow isolation. However, the mother must practice good hand hygiene before she decides to embark on lactation. She must have her appropriate PEP before she decides to embark on it as well. And from the case series that have been, it's been shown that the level of transmission is very, very low. However, information is still dynamic at this point in time, and more series are still being entertained. So, most importantly, of course, when a woman has just put to birth, you expect the mother, either of the mother of the husband or the wife. So that's caregiver, family caregiver must be also educated properly on safety measures. Safety measures. You must wear your mask. You're feeding baby, you must observe your hand hygiene. It's really sensitive to tell mommy, please now, you're not wearing your mask, but try and do it, because at the end of the day, it will help a lot. Some people have talked about bathing of baby. Of course, the nurse that will be doing that should be masked, and she should, of course, have her gloves. We've talked about breastfeeding. In our environment, it is encouraged. The benefits are a lot, and it definitely has a significant role. Now, luckily for us, a case report showed that there's no significant role of breast milk in the transmission of the respiratory virus. So that's something it's encouraging as well. We've talked about the hand hygiene, good respiratory hygiene vis-a-vis your mask, etc., etc. Now, the national guidelines that was just released has also talked about immunization schedule, and they said it can go ahead. Well, different health facilities have their own protocol. So they said it's advised to go ahead. And of course, 24 hours post-delivery, an examination of the neonate should also be done, looking out for any signs that may be suggestive of infection. Postnatal care visits can also be done effectively by telecommunication. So we can do teleconsultation for all our patients that have delivered. We can send them reminders, and then they can now hook up to the sites and then have their consultation. Now, importantly, if they need to come in, because during the postnatal period, it's an opportunity to have pap smear done. So that you don't have increased missed opportunities. It's also an opportunity to have breast examination. It's an opportunity to offer them child spacing, that's contraception. So when it's discussed and the time is agreed and everything is in place, we can now send them give them an appointment to come in, have this procedure done in the shortest possible time, and then they go back home again. So it's really possible during this period. Yeah, so let's look at the case studies that we've been talking about. Now, the case report by Wang et al., 2020. They reported a case of a woman with COVID-19 that required mechanical ventilation at 30 weeks. And 30 weeks is really remote from term. Well, she had lung maturation. She had the baby didn't have surfactant at birth. She had an emergency cesarean section, and she made both mother and baby made good recovery. So things are looking bright for us here. Another one by Chen et al. They tested the amniotic fluid, they tested the cord blood from infected mothers, and they also tested the neonatal throat swab and breast milk samples. And good news, all of them came out negative. We are so happy about that. Then another tested the placenta of 3 infected mothers. They also came out negative, which is really encouraging for us. So you see, counseling comes in, our clients come in, they are really agitated, they are jittery, they are concerned. We can, quote all these studies and then help to encourage them. If they practice, as long as they practice all those things which earlier spoke about, they should be in a safe place. Now, we talked about a series from another Chinese series that talked about increased fetal compromise, and that was what now necessitated electronic fetal monitoring in labor, which has been recommended now. And prior to last 2 months, it wasn't thought that COVID would be implicated in preterm birth. Most people were thinking that perhaps these high-risk patients that have had previous preterm birth, patients that have other risk factors, cervical incompetence, patients that have twin gestation, etc. But now the evidence, more case reports are being made of this preterm birth, so we need to really be observant about this. And it's an arid area for contemporary research. Now, another study talked about the maternal fetal and neonatal outcome in late pregnancy infection. So supposing a woman had the contact with an infected person late in pregnancy, from this study done by Yun et al., they showed that the outcome was encouraging, fetal outcome was encouraging, as long as intensive and active management is instituted. So this is also encouraging as well. So we've talked about this prior to now. And then, of course, another study, this was quite a large study, and their aim was to look at the symptomatology, the clinical course of this disease. And then, of course, like it's stated in the literature, fever ranked highest, dry cough, fatigue, sputum, shortness of breath, etc. And of course, the severe and critical disease as well. Now, down to the very, one of the questions asked by most medical personnel about treatment in pregnancy. Honestly, they are changing views. Nobody wants to come out and say and have a particular recommendation. However, this is what they said as an advice. Owing to the potential of COVID-19 to cause significant disease and mortality in pregnant women, the benefits of maternal treatment should carefully be considered against the fetal and neonatal risk. So meaning that most of these drugs they are developing, really, they have side effects. But once the benefit outweighs the risk, then we can have them in pregnancy. And this area is constantly changing. So a lot of studies have been concluded, lots are still going on, lots are being repeated, etc. I've not seen any drug that is a class A drug. Most of them are class C drugs. Class B drugs, benefits outweigh the risk. So we talk of the very common hydroxychloroquine, a quinine derivative. It's an anti-malaria, anti-inflammatory agent. It has a much more reduced toxicity than chloroquine, and it's implicated in increasing endosomal pH, which is required for cell fusion and disrupts glycosylation of cellular receptors. So the use of this has not been associated significantly with increased malformation in the babies, low birth weights, increased stillbirths, or prematurity. However, it showed a slight increase in miscarriage risk, and this increase was really attributed to perhaps confounding factors or even the methodological bias, because most of all these studies we are having, they are just case reports, case series as well, multiple reports, that's case series, case reports, and their scientific strength is not on the highest point of the ladder. So I'm sure a lot more research will still be going on. But if we are at the point where we need to do some form of treatment for the severe or even the mild, moderate case, hydroxychloroquine has been offered. Another agent is the azithromycin, the macrolide, and it has this immunomodulatory effect. Remember, we talked about the pro-cytokines that are produced by the body in the bid to kill the virus, and inadvertently causes more damage on its own. And also the neutrophils that are now attracted when the virus now is embedded in the cell, which is not without its own side effects as well. So this macrolide is implicated in this at this point. And it has been shown to be effective on pneumonia. And also when there's a secondary bacterial infection, azithromycin has been shown to be effective. Now it's also advised, because prior to now, it has been known to cause some fetal anomalies. However, it can be used if the benefit outweighs the risk. This is yet another drug, a humanized monoclonal IgG1 antibody, and it binds and inhibits the soluble and membrane-bound interleukin-6 receptors. Remember interleukin-6 that goes and stimulates the hypothalamus and leads to all those, the fever, etc., etc. It binds this, and then the evidence also is limited regarding fetal effects and adverse pregnancy outcome as well. So the evidence really is also limited here. So it has been advocated too if the benefit outweighs the risk. Enumerated are the other ones that have been used. Interferon beta, very important, because interferon beta has been shown to have good effects too, has been shown to have encouraging effects in pregnancy, though the benefit must also outweigh the risk. So basically, these are the drugs. These are some more drugs. Advised, should be used with caution, etc. In conclusion, the obstetrics population presents a unique challenge during this pandemic because patients have multiple interactions with the healthcare system, and eventually most are admitted. Focused antenatal care or focused care and indicated visits are key to ensuring minimal community transmission. Minimal intervention with route of delivery determined by obstetrics indication should be the goal. Most importantly, adhere to domesticated protocols for local settings cannot be overemphasized. So these are the references. A lot of China studies, some from New York, from US and all that. Then of course our guidelines by Federal Ministry of Health of Nigeria, and then WHO remark, etc. So we have a lot of references here. Thank you for listening. Any questions? Hello?
We'll take questions now. So anyone that has questions may just put up their hand. Dr. Osaji is a consultant gynecologist with the Hospital Group. Dr. KK is also standing by. Dr. Oji, the head of O&G, the Living Hospital Group, is also available to answer questions. So Within 3 of them, we'll be able to answer all the questions. Somebody has asked a question about where the guidelines are from. So I think it's a combination of every day. There's nobody that has a full guideline, but it's a combination of what American College has put together, Royal College, what is locally available, and from case studies and what we can locally adapt to our unique environment. So I'll take questions now. If you have a question, you may put up your hand. There's an icon that says put up your hand. So Dr. Okeke, Dr. Oji, you can stand ready. While Dr. Nicole refreshes. Lawrence Ogo has asked, please, are patients allowed to have elective CS if they choose to with no other obstetric indications? I think that's what he's trying to say. Please, are patients allowed to have elective CS if they choose to with no other obstetric indications? Dr. Oji, maybe you can go ahead.
Thank you very much for that question. And thank you, Dr. Nicole, for a very exhaustive webinar presentation. It was well researched.
Thank you, sir.
The area of elective cesarean section by request is a controversial area internationally. Knowing that where there is no indication for the cesarean section, excuse me, where there is no indication for the cesarean section, the strain and the cost of an unindicated cesarean section on the health system is quite questionable and unwanted, especially in this era of COVID-19 disease. There is a push to try and reduce the pressure of elective surgeries where there are not emergencies. In many centers, elective surgeries, except for things like ectopic pregnancies and incomplete abortions, are being postponed to later dates. So doing an elective cesarean section that is not indicated is not recommended at this time. I hope I have answered the question.
Yes, okay. The next question is, thanks for the great presentation. Some people will argue that it is spread by droplets and not aerosol. What is your take?
Thank you.
Okay. Go ahead.
Hello. Hello.
Yeah, go ahead, we're hearing you.
Okay, thank you very much for that question. Well, yes, it is spread by respiratory droplets. However, I remember recall I said a lot of dynamics, a lot of changes. There has been studies that showed aerosol is one of the great important means of transmission as well. So respiratory droplets, yes. Aerosol as well. So we should be very, very careful. Hello. We should be very, very much aware of all the methods of transmission of this virus.
Okay, so both aerosol and droplets are, I think for now, it is presumed that both are equally viable. So it is not safe for us to assume that it's only droplets. You must assume that it's aerosol induced as well, and take all necessary precautions in doing that. Okay, so the next question is, considering that COVID-19 orchestrates hypercoagulation syndrome with a commensurately higher prognosis for puerperal venous thromboembolism, among other things, are there any guidelines on a possible prophylactic intrapartum or pre-operative heparinization protocol?
Okay. Okay. Hello.
Yeah, go ahead.
Okay. So, yes, there's been postulates that hypercoagulability it's also a mechanism, especially during the severe form of COVID-19 infection. However, this has been a topic of debate. A lot of people insist that there is vasodilatation, leaky capillary membranes, and then of course shift of fluids. While others insist that with these leaky capillaries, there is endothelial damage, and then the intrinsic pathway is now activated, and there's this consumption coagulopathy that leads to DIC. However, in the obstetrics community, just for the singular reason why that we've not had a handful of cases of severe disease, we don't have any guidelines for that as we speak now. But by tomorrow, I'm sure someone will come up, Israel, US will come up, and then they'll give us their own case report or case series and then bring up their own guideline. But as we speak, like Chief said, all these guidelines is a direct combination of 3 powerful guidelines, including our own national guidelines. And these guidelines have emphasized that they are advised. Nowhere in these guidelines have anticoagulation come up. But it's an area of arid research and it's constantly changing though.
Okay, so I think generally the idea of increased thromboembolism or hypercoagulation, and I'll have Dr. Ofisoye, a consultant physician, also chip in on that. The idea of hypercoagulation is still a matter under debate. People are not sure whether the hypercoagulation is a comorbid factor rather than a cause or an effect of the disease, of the COVID disease. So it's not very clear as of now. We know that people that are bedridden with pneumonia are at a higher risk for thromboembolic phenomena and all that thing. Meanwhile, those patients that are also found to have this close also have other risk factors for hypercoagulation: diabetes, hypertension, obesity, heart failure, and then they now have clots. So it is likely so, but as of now, there is no clear-cut indication for that, and you should be very careful when you are doing it. Suffice to say, however, that if you have to keep a woman on bed for a long time who has COVID, it may not be a bad idea to start some prophylactic anticoagulation, but that will be up to the gynecologist to give us anything. Dr. Okeke, you want to say something? Dr. Okeke, you want to say something?
Are you true? Well, what actually, thank you everybody, Dr. Okeke, consultant gynecologist. I've actually wanted to add something to the presentation, the beautiful presentation by Dr. Osaji, so that she has actually done some justice to that before the patients actually are supposed to have started coming in, so that we could also make some other things. Trying to say that COVID-19 pandemic and pregnant states. So we generally know that the pregnant state is actually a sort of reduced immunity state, and therefore the higher susceptibility actually has been raised, in as much as the literatures are not yet conclusive. But being a sort of pregnancy, being a sort of reduced immunity, so these things, there's a fear for the pregnant woman being more vulnerable to serious complications of COVID-19. So there is that attached. Also, we also know the physiology of pregnancies as increased respiratory rates, higher susceptibility to malaria infestation, especially for the primary gravidas, which we all understand the physiology, which is subsequent fever and all the rest of it. All this actually may mimic features of COVID-19. And also, one other thing again I want to say is that in a pandemic situation as we currently have, universal precaution is the major thing, which has been stressed and stressed. So because many of the patients who actually be coming to these facilities we have may be asymptomatic. Therefore, you know how to remember the universal precaution, what you need to do. And as she stressed, their counseling is important. But the area I wanted to say, because so many information actually is in the social media, and some of them can be very scary to some of these patients. So that's why sometimes some even if I advise that Please leave all these carrying messages from social media. Confirm from your doctor, just like the way we normally advise our antenatal women and even postnatal women who are delivered as we are doing. Confirm. So not every information you get from the social media is true. So a lot of false news are there. So confirm from your doctor. So we always counsel our patients. We need to do that. She talked about the spacing of antenatal visit, focus antenatal care, which actually we practice in many hospitals. But even now, it becomes much more important, even emphasizing it more, spacing the visits as appropriate, as you say, the pre-appointment, and using other creative methods like the counseling and the video talking, like she said. These things are very, very important in what you have said. Now, what we also want to say is that in as much as she went through the whole gamut of all the presentation, antenatal, labor, delivery, others, we want to restate what the Federal Ministry of Health and NCDC has been saying. It is the centers that are accredited to take delivery and manage this patient actually the one to do it. It's not clear for us to, if your center is not accredited, please don't engage in that. So these protocols are all out there for the centers that are visible. However, a patient presenting a suspected case, of course, they need them to, the referral to those places becomes important. Unless, as in maybe when it comes to delivery, maybe it comes in advanced case labor where the patient now came in and then other histories you are now having is pointing towards that. What do you do? So that's where now some of all these things are very important, as we normally say, because not everything that some of the things that she has highlighted that they're not going to make use of. And as the question actually, she said very well that it is the objective indication that determines the route of delivery, and not by choice or any other thing apart from those who are having a severe respiratory problems. And another thing again, I also want to say is that even for where you have at the advanced labor, in the advanced case of labor that presented with having symptoms suspected of COVID. So please, the appropriate PPE must be worn, and a reduced number of staff have to be in the labor room. These are very, very important things as a way of preventing the health workers from being infected. Because from the information we are getting a few days ago, that more than hundreds of us living in this environment in Nigeria have actually been affected. So the health worker had to be alive for his family and also to save other ones. And the other thing is I want to talk about the treatment. We say that in a pandemic situation, so a lot of people are trying a lot of things, which somehow say is allowed. Yes, true. However, in pregnancy, we weigh the risk of treatment and the consequences that may actually be there. But in the first trimester, where you have the viability of pregnancy not yet established, of course, the mother's life becomes more important. And just like we also do where we have some other more serious cases like cancers, pregnancy-associated cancers. So where the pregnancy is not yet viable, what we do is that counsel the patient or the couple as if the case may be, terminate the pregnancy and give the appropriate care. So this actually becomes important. Or even when it's closer to viability, closer to maybe 34 weeks or thereabout, mature the lungs of the baby and deliver your, right? So we needed to add some of these things so that when the question starts coming, some of them will be highly highlighted. This is actually why I was raising my hand. Thank you so much. We are still waiting for the questions.
All right, so there are more questions here. What do we do when a mother suffering from COVID-19 is deteriorating and in third trimester? Is there a room for C-section so proper care of the mother can take place? What do we do? Is there a room for C-section for a mother with COVID-19 deteriorating and in third trimester? Is there a room for C-section so that proper care of the mother can take place?
Of course. Just like even there should be a room for that where we have even cases, even without the COVID-19, we have a perimortem cesarean session in some cases. So as we have maybe with RTAs or women going to heart failure or some other things that are about taking the woman's life. Of course, perimortem cesarean. So but all this are done because even the woman who is presenting with the COVID-19, which is actually a medical condition, that apart from the obstetrics part of it, that the woman is pregnant. So in conjunction with the physicians and other people who are managing, and also consent of the partner. Of course, emergency resuscitation could be done to salvage the baby, and then while the appropriate care will be given to the woman.
Oh, okay, Doctor. Or do you have anything to add, Dr. Nico? Dr. You can go ahead, unmute yourself.
Okay.
Go ahead.
Yes, just to quickly add something to the last response Dr. KK made regarding whether a deteriorating pregnant woman at 30 with COVID-19 disease can have cesarean section done in order to be resuscitated properly. Of course, his answer is on point. And just to quickly add that the 47% rate of preterm deliveries that we have had in COVID-19 disease in pregnant women and management is actually because the mothers with severe disease received cesarean sections, most of them in China, in order to enable the mother to be resuscitated. So, and the results that have come out of that have been quite encouraging. Yes, so ending a pregnancy in order for the mother to be better resuscitated and recover quickly applies strongly in this case.
Okay, we're going to move a little faster now. Thanks for the presentation. I think Dr. Nicole, in one of your slides, as regards the use of masks for pregnant women, you said not to use N95. Can you explain why?
Okay.
As regards the use of masks for pregnant women, you said not to use N95. Can you explain why?
Okay, thank you so much. So from the slide, I said that we were talking about triaging at the once she presents to the hospital. For triaging, a patient that is suspected or one of your clients that just comes into the hospital, you don't need to insist that they should use N95 mask. According to the national guideline, these are national guidelines, a surgical mask or even they called it procedural mask, which I assume to be a cloth mask, will suffice. Because if you start insisting that all your clients coming into your hospital should buy the N95 mask, that costs, I think, 12 to 15,000, they'll end up making a scene there and leaving the hospital. So it's been categorically stated, and that's why I said you don't need to insist on those pregnant women just coming in for their antenatal visits to wear the N95 mask. The surgical mask or the cloth mask will suffice for them. So that's according to the guidelines. That's what I meant.
Okay, there's another question here. It says, considering the antiphospholipid antibodies that have been found in virtually all pregnant women with COVID-19, can aspirin be considered? Are there any implications for pregnancy loss?
Okay, thank you very much. So, but I didn't get the second question. I got antiphospholipid antibodies.
Yes, he said since antibodies are found in virtually all pregnant women with COVID-19, can aspirin be considered?
Okay.
And is there any implication for pregnancy loss?
Okay, beautiful. Thank you very much for that question. All right, so a case report I saw from, I think, Israel said they used 500 milligrams of aspirin on women and they had good outcome. But in the American College of Obstetrician and Gynecological guideline, the Royal College of Obstetrician and Gynecologists guideline, and our national guideline, there is no place for aspirin use yet, because there's a divide between those that are pro hypercoagulability as a cause or a course in the COVID infection. So no series, it's not a universal accepted pathogenesis, and no guideline has stated the use of aspirin. However, some people have used it and they have had good results. So at the end of the day, if a local study can bring up something and is suggested into the guideline, then of course we can go ahead. But as we speak, the ever dynamic pathophysiology is still what is on now, and no guideline has stated, indicated, or even advised the use of aspirin in the management of COVID-19 in pregnancy.
Okay, Dr. Oji, over to you. It says, what is the role of assisted vaginal delivery in COVID-19 patients? What is the role of assistant, Suleiman asked, what is the assisted vaginal delivery in COVID-19 patients?
Thank you very much, Dr. The role of assisted vaginal delivery in COVID-19 patients. It's like Dr. Keke clarified earlier on. In centers where COVID-19 positive patients are being managed, that is those designated centers where they are being managed, we expect that those are the centers where the pregnancies and delivery will be taking place. We expect that there are adequate facilities in those designated centers as well as the manpower. Now, one of the recommended special points in the second stage of a pregnant woman with suspected or confirmed COVID-19 in labor is to shorten the second stage. So there is a place for the use of vacuum to shorten the second stage in management of a pregnant woman with COVID-19. It is recommended.
Okay. Somebody said, what sort of mask would you recommend for doctors to use when giving intranasal oxygen for intrauterine resuscitation?
Thank you for that question. Giving intranasal oxygen for intrauterine resuscitation, of course, it depends on whether one is dealing with a suspected or a confirmed case or a regular low risk of COVID-19 pregnant woman. In the case of low risk of COVID-19 pregnant woman, as it's obtainable in our center here, every staff of the hospital and patients present are expected to wear a mask. So the routine surgical mask, or the patients are even allowed to wear just the cloth mask. So if one is giving oxygen to a low risk or no risk pregnant woman, there's no a routine surgical mask would suffice. But even where there is a high risk of aerosolization, for instance, where general anesthesia is to be given, where suction and other aerosolizing procedures are to be done by medical practitioners or medical professionals, they are advised to use N95 mask. But just putting oxygen in a pregnant woman in labor in this COVID-19 era is not one of those indications where N95 must be used by the physician. A regular surgical mask could suffice.
Okay, so I'll just add that I think the patient should also, even despite being on oxygen, should still be on a face mask. And most people, including some people that are managing COVID-19 patients here in Nigeria, have said it's better to keep your oxygen flow rates at less than 2 liters per minute, so that you'll be able to reduce the risk of aerosolization. So don't give very high airflow oxygen flow rates, like greater than 4 liters per minute, 6 liters per minute. That may be too much in this instance. So I think it may be better to keep your low flow rates until absolutely necessary. Okay. There's another question. Pronin is being touted as a game changer in COVID-19 case physiotherapy. Is it advisable in pregnancy, or should I say, is it feasible in pregnancy? Dr. Nicole, Dr. Oja and Okeke are together. So what do you think? They say proning, that's lying prone. I don't think it is feasible. I don't think it is feasible. Dr. Ruapa has asked. So definitely is advisable, but it's not feasible. So this is where one of the indications for delivering the woman properly so that you can have proper care will have to come in, I think so. So any of the gynecologists, can you go ahead?
Dr. Oraba's question. Pruning is being found to be beneficial in non-pregnant individuals that have COVID-19. It is thought that the pruning recruits some alveoli and the posterior inferior aspects of the lung. But where a woman has pregnancy, pruning is completely contraindicated. Rather, we advise still that the woman should preferably lie her left lateral position in order to avoid prevent orthocaval hypertension. So pruning is not indicated in a heavily pregnant woman.
Okay. Somebody asked what proportion of confirmed cases in Nigeria are pregnant. I don't think NCDC has not releasing a lot of data to the medical community. Exactly. So except anybody has an insider information. Go ahead.
Okay. Let me say something. Actually, the incidence of pregnant women that but the same male-female ratio is actually about 70-30. So we see that more preponderance of the male population are actually having the COVID. And I think that somehow, at least with the issue of traveling and all the rest of them can account for that. But for the population of pregnant women infected, no, we don't have any of such for now.
Okay. Somebody asked if COVID can be diagnosed using stool sample, considering the fact that it is transmitted via feces. Let me allow Dr. Aofisoye, consultant physician, to attempt to answer that. Say, can COVID-19 virus, Dr. Aofisoye, I've unmuted you. Can COVID-19 virus be diagnosed with a stool sample, considering the fact that it is being found in feces? Whether it is, I don't think it's transmitted by feces, but there are new reports that say it's being transmitted by feces. Dr. Aofisoye, are you there?
Yes, I'm here. Can you hear me?
Yes, I can hear you.
Okay, so yes, COVID-19, the coronavirus antigen samples has been found in stool, okay? But it has not been shown to be useful for diagnosis purposes. And it's not likely to be useful for diagnosis purposes because the time people probably start shedding the viral particles in stool, usually the illness will have been far on by then. And from some of the reports, it suggests that even though shedding of the viral particles in stool lasts beyond the time of the active infection, if you understand what I mean. So it's not used for clinical diagnosis of, it's not useful for the clinical diagnosis of the infection for now. So that's just been my short answer for it. We should not forget that it's primarily a respiratory pathogen, and the yield during the relevant time of the clinical syndrome is mostly in the respiratory system. So even the yield of blood samples for the coronavirus is very little, at least initially. I'm talking about antigen tests now. And the yield of the stool is likely later on along the course of the disease, and it's probably not so useful to make a diagnosis at that point. And it has not been shown to be useful for diagnosis purposes at all. It was just found when studying ways in which people are shedding the virus. So that's my answer.
All right, thank you very much. Dr. Suberu, a consultant pediatrician, says vertical transmission of COVID to the neonate is not yet clear. However, does vaginal delivery increase the risk in view of the direct contact of maternal secretion with the neonate, especially the eyes, nose, and mouth? Dr. Nicole, I think you said something about that, but maybe you go ahead.
Yes, thank you so much for that question, Dr. Suberu. Yes, definitely. There was just one case that was reported, one case report that showed vertical transmission, which really has helped us, giving us a kind of hope concerning COVID and during the antenatal period. However, we've not had any case reports that showed increased risk comparing two, perhaps two cohort, those that have had cesarean delivery and those that have had vaginal delivery. Like Chief said, Dr. Oji, he said the cases that were reported, 47%, they had preterm delivery because of the severity of their disease. So there was an indication for the cesarean delivery, not because they were thinking that going through the cesarean route would necessarily reduce the chance of having the infection. And also from the studies that have been reported, though there are case reports and case series, it's been shown that there is no evidence of COVID in amniotic fluid, which of course baby is bathed in antenatally, and baby is ushered into the world with the fluid during delivery. There was no, they all tested negative with placentae that were all reviewed. In another case study, 3 of them, none of them tested positive. So I would not categorically say that there's a significant increase, or even if there's an increase in infectivity based on the route of delivery.
Okay, so he said, somebody asked a question, is artificial rupture of membrane allowed in COVID-19 patient in labor? I will perhaps allow Dr. Oji and Dr. Keke to take that one. Is artificial rupture of membrane allowed in the management of COVID-19 patients in labor?
Well, yes, of course. What's actually happening is that for a patient that actually in labor and presents in the hospital as suspected COVID or even a COVID patient being managed and that is being by the multidisciplinary team. Of course, ARM can be done. And it's just that the person doing it that you have to do on your full PPE and full PPE and other precautions actually necessarily done. Because definitely, if you don't do ARM, definitely you're not likely to, the labor will not progress or even the baby may not be delivered. But the important thing is to observe all the precautions that is necessary.
Okay, I think we have finished most of the questions. There's one last question I can see here. How can we prevent preterm labor in COVID-19 pregnant patients, especially in the rural areas? Maybe I'll allow Dr. Nicole to talk about that. She talked extensively about preterm births in COVID-19. So how can we prevent preterm labor in COVID-19 pregnant patients?
Thank you so much for that question. In terms of prevention of preterm labor, well, of course, you would need to get them at the appropriate time when they are having preterm contraction. And then when appropriate management is instituted, that negates the chances of them ending up having preterm labor. The things that, the management that could be instituted after making a diagnosis of preterm contraction could include: 1, isolating an etiology. If she's having perhaps fever, which may be prevalent because we're in a malaria endemic zone, may be prevalent in the rural area. Once we notice she has a malaria positivity, we treat it immediately. If she has features of UTI, that is treated as well. If she's having vaginal pleuritic vaginal itching and pleuritic vaginal discharge, she should be treated as well. That will halt the natural sequence in final occurrence of preterm labor. Also, if she has had a preterm delivery before, in the rural area, now rural areas are getting closer because now we are in a global village. Most rural areas have some form of ultrasound scan, and a woman that's had a preterm labor before, you can prevent another preterm labor by assessing her cervical length. Right now, a lot of NGOs have gone into teaching nurses, midwives on how to scan. So if you notice it's reduced cervical length in the first trimester, you can institute, you can refer her to a center where a cervical sacrilege can be done in the bid to prevent preterm labor. And also, drugs like tocolysis are commonest ones, the nifedipine, the salbutamol, or as the case may be, Sometimes we use progesterone suppositories. I think they should be available in the rural areas, and this should be instituted at the appropriate time once you have met with the indication to prevent the last phase, the tail end of preterm contraction, which is preterm labor. And also teaching them good practices, of course, like of course their hygiene, personal hygiene, etc., to reduce the amount of infection, and encouraging them in trying to eat their local diets that are balanced will also help in a way to prevent preterm labor to an extent. So I think those are my thoughts on that question.
All right, thank you very much. Let's have some final comments from Dr. Oji and Dr. Keke.
Again, thank you for a fantastic presentation. Part of my final comments is regarding the last question as well. Like Dr. Keke had emphasized earlier on, we do not expect medical practitioners in uncertified or unaccredited centers to be attempting management of COVID-19 positive pregnant women or COVID-19 positive persons of any sex or gender. We expect that medical practitioners and the facilities where they work take very strong proactive measures to screen patients, isolate suspected cases, and notify the appropriate authorities who would come and take over management from there. Let me quickly mention that there are some hospitals that are currently closed down in Lagos because either they have, and other places in the country, either because they inadvertently managed COVID-19 positive cases or actually admitted and treated without being certified. And like Okeke also mentioned earlier on, a significantly high number of medical workers, either doctors and paramedics alike, have been found to be infected with COVID-19. And a number of deaths have also arisen in medical professionals due to this. So it is very important, like he said, that we survive to fight this battle till the end. As a matter of fact, it is still unpredictable how this curve is going to go in Nigeria. It might just blow up over the next few weeks, God forbid. We hope it plateaus and goes down. The medical practitioners need to stay safe in order to play the significant role that is required of us down the line in the management of all these cases. So for now, there are designated centers. We need different centers where we are, like the rural area where the last question is referring to have a high index of suspicion, identify a suspected case, and notify the authorities to take over from there. So I also want to quickly mention in the intrapartum care of pregnant women that, like I mentioned earlier on, while during the vaginal delivery, that we prefer to shorten the second stage. Those are just some little additions. And if while doing CS, we prefer to use spinal anesthesia or epidural anesthesia. This is to avoid the aerosolizing risk of general anesthesia that will require intubation and all of that. Essentially, those are some of the additions.
All right, thank you very much. Dr. Afusoye, do you have anything to add? Dr. Afusoye is a consultant physician with the Limit Hospital Group with Cardio Care. He's the medical director of Cardio Care. Do you have anything to add?
I think it was a beautiful presentation, and I think we've covered all necessary areas. So I give it again to the ONG team led by Dr. Nicole. Thank you very much.
All right, thank you very much, everyone. The presentation was brought by the Limit Hospital Group, which consists of Limit Hospital in the central area, which has the ONG team, ENT, neurosurgery, and all multiple specialties. Cardio Care is where we manage internal medicine cases, our ultramodern ICU, cath lab, echoes, ECGs, and all the physicians in Cardio Care Hospital under the Limit Hospital Group, internal medicine, cardiologists, endocrinologists, and all that. And the Children's Hospital is where we take care of neonates, preterm deliveries. So whenever the O&G team is having a preterm delivery, the children's hospital stands by with their mobile incubator so that they move the baby, immediately the baby is born, from as low as 24 weeks, 25 weeks. We move there, we give surfactant, we intubate, and we try and deliver the babies as much as possible. We are not currently managing COVID because we have not yet been certified for that. But everybody has to be alert. With the rapid way of rise, we should all be alert that this may quickly spiral out of, it may be an everyday disease like malaria if we are not careful. So I think every medical practitioner needs to be prepared ahead of time. Suffice it to say that you should assume that every patient has COVID. Don't wait for them to tell you the status or wait for it to be confirmed or not. If you assume that every woman has COVID, then you will take appropriate precautions. Wear necessary PPEs for every labor. The woman as well should also be wearing a face mask even during labor. Yes, you have to be encouraging and be cautious with giving high flow oxygen, which is known to aerosolize the virus if it is present. So you don't want to find out later the woman is positive and then you are now running around the place. So take necessary precautions upfront ab initio. So these are the hospitals that are sponsoring this. There are other presentations that have been done. Hypertensive crisis was treated by the cardio care team. Also an approach to a patient presenting with difficulty in breathing. So any patient presenting with difficulty in breathing, how do you approach them? And don't forget that pregnant women with chorioamnionitis, with draining liquor, will also have fever, will have tachycardia, will also have tachypnea and some difficulty in breathing, which can also look like COVID. So do you send the patient away? What do you do? Okay, so there's an approach to handling patients with difficulty in breathing, what to consider. Some patients may also have background heart disease and they are pregnant and not having breathlessness. There are a lot of allegations of people that have died who were thought to be COVID positive and were abandoned by medical professionals. And so there is a need for all of us to have some level of knowledge when going about this. If you have any questions further about this, about 1.5 to 2 CME points, let's check the time, about 2 CME points will be given to doctors that have attended this. So you can send a mail to cardiocaresymposia@gmail.com. It's on your screen. That will be sent sometime mid next week. And if you have any other issues or problems connecting, you can send a WhatsApp to the number on your screen, 0809-333 Limi. You can follow Facebook and Instagram, Limi Children's Hospital, and on YouTube. In the next 3 days, in 72 hours, I've seen a lot of questions about people asking, will there be video for this? Yes, there will be video for this. The video is being recorded and it will be available on YouTube, the Limi Hospital Network. So if you go on YouTube right now, subscribe and click notifications so that you can get the video, you can get notified once the video is uploaded. You also find there other videos on hypertensive crisis, on approach to difficulty in breathing by Dr. Alfisoye taken earlier, and a particular focus on COVID. So if you go on this YouTube channel, you should be able to get the previous videos and watch. They are quite enlightening presentations for you all. Now, going forward on Friday, we are going to have another presentation, another webinar. In this case, we'll be going back to the internal physicians where we'll be doing chest pain. And the week after, we'll be going on to do neonatal distress and the approach of pediatrics to COVID-19 infection and how pediatrics should hold. So that will be hosted by Children's Hospital. Chest pain will be hosted by Cardio Care. And then we'll answer any questions. If there are any topics you'd like us to discuss, it's not a bad idea to perhaps send the mail. Then we'll see the ones that are most prevalent and the ones, and we'll gather our specialists all together to handle those cases. Okay, so once again, Limi Children's Hospital. Cardio Care is an ultra-modern facility by Limi Hospitals. It's in Gariki area 11. It has its modern cath lab and a very brand new facility, which you can see on the screen. We do a lot of interventional cardiology, diabetology. Now we know that the patients we manage in cardio care are also patients that are at high risk for COVID or for complications of COVID. Also, sometimes it's very difficult to differentiate a patient with high blood pressure coming with heart failure, breathlessness, from a patient coming with breathlessness from COVID. And so sometimes it's a challenging thing, but that's where some specialists come into play. So that's cardio care in Gariki. And the Children's Hospital does the preterm delivery and pediatric cardiology and pediatric subspecialties. At this point, we'll be coming to a close once again, look at the screen to get the necessary information about contacting us. Thank you very much for joining us. We really appreciate you. Send us mail, send us what you think. We'd like to have, we'd like to work with you. I can see 2 hands are raised. Let me try and see if I can attend to the hands that are raised before we go. Thank you for the presentation. Sorry, I can't see the hands again. Am I the one that does not use this? Okay, I thought I saw 2 hands raised. Maybe it was a mistake. Okay, so thank you very much. God bless you. Have a nice weekend.
So thank you.
Thank you.
Thank you.
That is solution. And try. At least to survive, keeping people at least, and also